All right, today we're tackling a big one, portal hypertension. Now that sounds complicated, right? But what if I told you we can break it all down by thinking about it in a really simple way, like a major plumbing problem happening inside your body?
So let's just run with that idea for a second. Imagine your whole circulatory system is this intricate network of pipes, and smack in the middle you've got the liver. It's the main filter. So the big question, the one that frames everything we're about to talk about, is this. What happens when that plumbing gets a serious clog?
Okay, here's our game plan. We'll start with the high-pressure problem itself. Then we'll figure out how to find the blockage and what warning signs to look for. After that, we'll cover the diagnostic toolkit, how to release the pressure, and finally, what happens when the system fails. Let's get started.
All right, first up, the high-pressure problem. And a great way to think about this is like a pressure cooker that's just building and building steam inside you.
So what is it exactly? Well, portal hypertension is pretty much what the name says. It's elevated pressure. We're talking about high pressure in the portal venous system. You know, that's the whole network of veins that's supposed to carry blood from your gut to your liver. And when something gets in the way and obstructs that flow, well, the pressure just backs up. It's literally like a blocked drain pipe in your house.
So what's a normal pressure level look like? Well, in a healthy person, the pressure in this whole network is super low. It just kind of sits comfortably between 5 and 10 millimeters of mercury. Everything's just flowing along nice and easy. But once that pressure starts to creep up and hits 10 millimeters of mercury or more, we've just crossed a really important line. This is what doctors call clinically significant portal hypertension, or CSPH for short. And this is the exact point where they start to get worried, because the risk for serious problems really starts to climb. And then, if it keeps going and gets above 12, now we're officially in the danger zone. Seriously, the pressure is so intense that it can cause these fragile, swollen veins, they're called varices, to just burst and bleed. And that, right there, can be a full-blown, life-threatening emergency.
Okay, so we know it's a plumbing problem. What's the first thing any good plumber does? You gotta find the blockage. Let's track down the source of this backup.
So when doctors are trying to pinpoint the problem, they think about it in 3 main locations. Is the blockage pre-hepatic? That means it's happening before the blood even gets to the liver, maybe something like a clot in the portal vein. Or is it hepatic, meaning the problem is inside the liver itself? Or could it be post-hepatic, where the traffic jam is happening after the liver, maybe because of something like heart failure?
Now, look, there are a bunch of things that can cause this, but in the United States, one culprit stands way out from the rest: cirrhosis. We're talking about severe scarring of the liver. I mean, just picture it. That scarred, stiff tissue is literally squeezing the blood vessels that run through it. It's like it's strangling the pipes from the inside, and that creates a massive backup.
Okay, so when you've got this much pressure building up in a closed system, it has to go somewhere, right? The body tries to get creative and starts making these little bypass routes. But those detours, they create some really obvious warning signs. This is how the body screams for help. And the consequences of this backup are no joke. The blood is so desperate to find a way around the liver that it starts carving out these dangerous new paths, like esophageal varices in the throat. You can sometimes even see a network of veins radiating out from the belly button. That's called caput medusa. The spleen gets all congested and swells up, and when it does that, it starts trapping platelets so your platelet count drops. That's a huge clue for doctors. All that pressure can also cause fluid to just leak out into the abdomen, a condition called ascites. And maybe the scariest one, all the toxins that the liver is supposed to filter out, they bypass it completely and go straight to the brain, causing major confusion.
So you see these signs. How do doctors actually figure out what's going on for sure? Well, they've got a whole diagnostic toolkit they can use to investigate, and they usually start with the simplest tools first.
The first thing they'll almost always do is an ultrasound with Doppler. It's totally painless, non-invasive, and it lets them get a first look at what's happening. They can see the blood vessels, check their size, and even watch which way the blood is flowing. And if they see it flowing backward, that is a classic telltale sign of a major plumbing backup.
Okay, this next part is actually pretty cool. To avoid doing something invasive, doctors have a clever trick. They use a special type of ultrasound to measure how stiff the liver is. Then they take that number and look at the patient's platelet count. And as you can see from this table, if you combine those 2 clues, you can get a really good idea of what's happening. A really stiff liver, especially when the platelets are low, is a dead giveaway. Like, look at the top line. If the liver stiffness is over 25, it doesn't even matter what the platelets are. The diagnosis is confirmed. But if they need the absolute, definitive answer, the gold standard is a procedure called an HVPG. This is more invasive. They actually thread a catheter into the veins of the liver to measure the pressure directly. Another way to get confirmation is with an endoscopy. They can send a tiny camera down your throat, and if they see those swollen varices in the esophagus, well, that's direct visual proof that you've got a serious high-pressure problem.
Okay, so you've got the diagnosis. What now? The goal is crystal clear. You have got to release the pressure. And there are a couple of ways to do it, both with medicine and with procedures. Think of it like either turning down the faucet or just installing a whole new bypass pipe. So let's look at the two main strategies side by side. On one hand, you've got meds, specifically something called non-selective beta blockers. These basically act like a pressure reducer. They lower the amount of blood flowing into the whole portal system, which brings the pressure down. On the other hand, you've got a procedure called a TIPS. This is the bypass pipe option. They literally go in and place a stent that creates a shortcut, letting blood shunt directly past the blocked up liver. It drops the pressure almost immediately.
So, when do you pull out the big guns and install that bypass pipe? Well, the TIPS procedure is really saved for the most serious cases, like when someone has bleeding that just won't stop or a belly full of fluid that medication can't touch. But you have to be careful. It's not for everybody. Remember how the liver filters toxins? Well, since the TIPS shunts blood around the liver, it can make things worse for patients who already have brain fog from those toxins. For them, it's an absolute no-go.
And that brings us to our last section. What happens when, despite everything, the pressure stays high and the system starts to fail? This is where things get really critical.
Now, here's a really important distinction doctors have to make, especially when there's bleeding in the stomach. There are two conditions that can look similar but are totally different. The first is called portal hypertensive gastropathy, or PHG. It has this kind of snakeskin look, and it's caused directly by the high pressure, so the pressure-reducing meds can help. The other one is called GAVE, and it looks like a watermelon stomach. The key thing here is that GAVE is not caused by the portal pressure, so those same drugs won't work at all. It needs a completely different treatment. Getting this right is absolutely crucial.
And that brings us to the single most important, most urgent takeaway from all of this. For anyone with known portal hypertension who starts showing signs of internal bleeding, you have to assume the worst. The rule is, think variceal bleed until proven otherwise. This is an all-hands-on-deck, drop-everything kind of emergency. It's not just a problem, it's a code situation. And that really drives home the life-and-death reality of what is, at its core, a high-pressure plumbing problem.